Hi, my name's Barton Jennings. I'm a respiratory physician based in Melbourne. I have a private practice which is called Lung and Sleep. We're based in Bentley in Melbourne, but we also do clinics out to country Victoria in Gippsland. I also have a public hospital appointment through Monash Health based in Clayton. At Monash, most of my work is actually centred around lung cancer and interventional pulmonology. I also do some general respiratory, and in private practice do mostly general respiratory and also sleep medicine. So today I'm going to talk about lung function testing and mainly concentrate on spirometry. We'll talk a little bit about gas transfer as well and where that fits in. But spirometry is a really useful test, and it can be done in most general practices, and so is very helpful in the assessment of patients with respiratory problems. Spirometry is useful to assess a patient with respiratory symptoms, so somebody might present, say, with cough or shortness of breath, chest tightness, and spirometry is really useful to try and determine what those symptoms might be due to. And the other main benefit is in people with known respiratory disease, so say for patients with asthma or COPD or bronchiectasis. Spirometry plays a really important part in assessing those patients and assisting in their management. So today, what I wanted to talk about is a bit of an outline as to how spirometry works and what are we actually measuring when we're doing spirometry for a patient. I think it's useful to, when we're thinking about that, to think about what the physiology means. And so when we see these numbers given to us, if we can understand where those numbers are coming from and how they're measured, it can help understand how to interpret them. Because ultimately, what we want to do is to come up with a diagnosis for the patient and work out a way that the spirometry can help us with the diagnosis and then, most importantly, help manage the patient. When it comes to interpreting spirometry, though, it can be quite complicated. And there are a few reasons why it can be complicated. And I think for those reasons, sometimes people are turned off trying to interpret the results. One of the reasons is that the spirometer, or the computer that does the test, spits out tons of numbers, too many numbers. And a lot of those numbers are actually not helpful. And so if we just concentrate on the numbers that are really helpful and ignore the rest of them, we can come up with an easy system as to how to interpret the results. The other problem is that the machine spits out the numbers in the wrong order and not the order in which they're best interpreted. And depending on where you get your spirometry test from, whether you do it in the office or whether you get it from a respiratory lab, and different respiratory labs will report their test differently. And so one patient might have spirometry numbers in one order, and then the next time you look at a spirometry test, all the numbers are in a different order. So it creates confusion, and I think that is really off-putting and tends to lead to people sometimes giving up or not trying to go through the process of interpreting it. So what I thought is useful is if we have a look at a system whereby any spirometry test we have, we can go through a certain system, makes it very easy to understand the results and make quick and easy interpretations. The spirometry is a type of lung function test, and it's probably one of the more simple lung function tests and most commonly lung function tests performed. It's really useful in the assessment of patients with respiratory symptoms, so somebody who may present with cough, shortness of breath, or in someone with a known respiratory illness such as COPD, asthma, or bronchiectasis. Spirometry essentially involves breathing into a machine where we inspire as far as possible and breathe out as quickly and as forcefully as possible, and we take measurements to determine how well a patient can get air in and out of their lung. So it's giving us a good idea about their airways and how well their airways function, and also tells us a little bit about lung volume. So when you're doing a spirometry test, essentially what is happening is that the patient will breathe in until total lung capacity. So get as much air into their chest as possible, and from there forcefully exhale as hard and as fast as possible, and continue exhaling until they cannot get any more air out of their chest. So once they reach that point, the leftover volume within the chest is the residual volume, and the amount of air that they've expired, the total volume that has been expired, is their forced vital capacity. So the forced vital capacity gives us a bit of an idea as to lung volume. But the lung volume, of course, includes the residual volume that we're not able to measure. So it doesn't give us an exact measurement of lung volume, but it gives us an idea as to what the lung volume may be. The other important measurement is FEV1, which is forced expiratory volume in 1 second. And that's measured during that forceful expiration. The amount of air that can be expired during the first second is the FEV1. And then the total volume, as I said, is the forced vital capacity, or the FVC. The next important measure is a calculation of the ratio of those two values. And it's called either the FER, which is the forced expiratory ratio, or sometimes put as the FEV1 to FVC ratio. And what this is that it's the ratio of FEV1, the amount of air you can get out in the first second, as a ratio of the forced vital capacity, which is the total amount of air you can get out of your lung. And that ratio should be 70%, or 0.7. What that means is that you should be able to get, of all the air you can get out of your lung, you should be able to get 70% out in that first second. And do you know how long it takes to get the rest out? So if it takes 70% can be expired in 1 second, the rest usually takes around 6 seconds. If that ratio is less than 0.7, then that is consistent with airflow obstruction. Airflow obstruction means that there's something obstructing expiratory airflow. There's something slowing down the ability to get that air forcefully exhaled from the lungs. So airflow obstruction may be due to narrowed airways, it may be due to the airways becoming floppy, it may be due to mucus within the airways, but something is slowing down airflow. So if you are unable to get 70% of your air within the chest out in that first second, there's airflow obstruction. So if the ratio is less than 70%, there's airflow obstruction. If the ratio is 70% or greater, there's no airflow obstruction. And so that provides us with probably the most important value when we're looking at a spirometry test, is that one value of the ratio of the forced expiratory volume in 1 second as a ratio of the forced vital capacity. It tells us whether there's airflow obstruction or whether there's not airflow.